more prone. Then what is the reason, what is the pathogenicity behind this COPDs? Tobacco smoking is the main risk factor. In addition to that, inflammation, imbalance of proteinases. If you remember, we have seen alpha-1 antitrypsin enzyme related diagnostic measure we have seen, and the presence of it. Just a minute, let me answer a call. Continue. Sorry, there was a phone. So what is the pathogenesis? We have seen that what are the tobacco smoking and inflammation, because of certain reasons it is there. There are other pathogenic mechanisms are also involved that causes changes. The mucous hypersecretion and ciliary dysfunction is there. Because of that, it causes obstruction in respiratory tract, and it also result into airflow limitations and hyperinflation. Then gas exchange abnormality, that gas is not properly exchanged, and therefore there will be hypoxia, there will be pulmonary hypertension, and systemic effects because of the hypoxia can be seen in the people. Then diagnosis of COPD, that is, it should be considered, and there are various things we already seen, and in that symptoms of cough, sputum production, dyspnea, then history of exposure to risk factor like smoking or mine or like that. Spirometry, we have already seen how it makes that is changes in, we have already categorized this as a diagnosis. We have seen it as a differential diagnosis, how to differentiate between bronchial asthma and COPD. Basically, bronchial asthma is also that way chronic obstructive pulmonary disease. But in COPD, bronchial asthma nowadays we take separate, and COPD in which emphysema and other diseases are there, that is taken as a COPD, and therefore how they are almost parallel. They are almost, we have seen in earlier case that there are so many diseases which are having similar signs, symptoms, and because of that it is very difficult, it is to basically diagnose it. So using that various steps, if we can do it, like spirometry, then assessment of risk factors, then checking the age of the person, and many other, so that can help, that can guide the expert to go for the proper treatment. Body mass index and dyspnea have proved useful in predicting outcomes like survival, and should thus be evaluated in all patients. So BMI values which are less than 21 kg meter square are associated with increase in the mortality. Functional dyspnea can also be assessed by the Medical Research Council dyspnea scale, that is 0 to 4 scale is there, that is not trouble with breathlessness except strenuous exercise, that when somebody makes the strenuous exercise only, then there is a breathlessness. Troubled by shortness of breath when hurrying or walking up the slight hill, then there is that, we'll call it as a 1. 2 means walks slower than people of the same age due to breathlessness and has to stop for a breath when walking at own pace. 3 means stop for a breath after walking about 100 meters or after a few minutes, and too breathless to leave the house, or breathless when even changing the clothes. So that means that is the severe form where oxygen supply reduces too much. Those clinically we can see about that disease progression, how it is there, how FEV go on reducing. Initially they can be at risk. If you see this in this way, start with at risk, in below you can find those who are at risk. Immediate treatment we can do is smoking cessation. Some symptoms start appearing. What happens? This symptom appearing, then we have checked, we find that FE1 is decreasing, and that is a slight decrease now, it is not too much. So this is there. Then we start about management of the disease from that. Then there is exacerbation. Because of that, at next stage, with that exacerbation, FEV is gradually decreased too much, and many symptoms are appearing. Then we are going, lastly it will be respiratory failure, where there are maximum symptoms or FEV or is almost zero, that means patient is almost leading towards death. So these are how we can correlate with diagnosis and this. Smoking cessation, there are many ways by which one can be done. It is the particular smoking is the most important risk, and this addiction can be done by many things. Then what it can be done is identify these tobacco users, strongly advise to quit, determine willingness, check whether they are ready. Then there are many ways by which you can do it. There are various plans you can have. Smoking cessation therapies are there nowadays, and accordingly we can go for smoking cessation therapies. So go for smoking cessation, use these various treatments are there, avoid it. There are nicotine patches and some tablets are available. So anything can be used, whatsoever is best for that. It is in that this clinician and delivery system must institutionalize the constituent identification, documentation and treatment of every tobacco users. This intervention is effective, and every tobacco user should be offered at least brief intervention. Strong dose response relationship between the intensity of tobacco dependence, counseling and effectiveness. So various things can be done. There are treatments, example of these are bupropion is one treatment, then nicotine gum, nicotine inhaler, nicotine nasal spray, nicotine patches, and at least one of these medications should be prescribed in absence of contraindications. So these 5 therapies are there for tobacco dependence or tobacco smoking cessation, we can say. So they are cost effective relative to other medical and other expenses which are there after COPD. Tobacco dependence removal or smoking cessation is very important. Now what we will do for COPD treatment? What are the pharmacological therapies? Oxygen, then pulmonary rehabilitation, nutrition, surgery and other things we shall see. So first one is a pharmacological therapy. What it is, the medication for COPD which are available, which can reduce or abolish the symptoms. And what are these? We can preferably administer these drugs by nasal route or by inhalation route. Let us see various drugs. Whenever there are changes in the forced expiratory volume in 1 second following bronchodilator therapy can be small, but are often accompanied by larger changes in the lung volume that contribute to reduction in the perceived breathlessness. We can combine different agents which produces greater changes in the spirometry. Just one. Hello. Ha. Hello. Ha. Ha. Tell me. Ha. Speak out. Ha. Yes, you can do it. And I think it is link. Listen. Link has been given on website. You check about it. Hello. You need not to come over here. No, I don't think so. But I'll check it in the meanwhile still. Okay. Most probably link is provided. I think if you'll read notice carefully, you will find that it has mentioned that it is an online process. Okay. So changes are there. We can combine various agents, and what treatment we do is bronchodilators, which are commonly given, like beta agonist, anticholinergic agents, and methylxanthines. If you remember, drugs acting on respiratory system, which we have recently completed in pharmacology. So these are the treatment. These are the way where they are acting. We have seen these already. That is how the drugs are acting. Once we confirm the diagnosis, then we have got various symptoms. What will go for that? The inhaler beta agonists or anticholinergic agents are given. Then long acting agents or initially short acting, but if the symptoms are persistent, then we'll go for long acting beta receptor agonist, then as needed. Then alternative class we can give, or we can have combination of these drugs. So this is long acting this beta agonist plus other agents. Then this all bronchodilator plus inhaled corticosteroids we can give ICS means. Then if there is limited benefits, then we can go for oral theophylline. So this is normal treatment. This is what normal algorithm for it. No big thing is there in that. So how we go for that? Short acting bronchodilator can increase the exercise tolerance acutely in this COPD. Anticholinergic can be given 4 times a day, can improve the health status over a 3-month period. Long acting beta agonist improve the health status possibly more than regular ipratropium. So they are more beneficial and comparatively less side effects. And this drug reduce symptoms, rescue medication use, and increase the time between exacerbations. We can add short-term agents like salbutamol or ipratropium produces greater change in the spirometry over 3 months than the single agent. So combination is always help. Combining long-acting inhaled beta agonist and ipratropium leads to fewer exacerbation than either drug alone. So this is also beneficial. Combining long-acting beta agonist and theophylline produces greater spirometric change than either of drug alone. So this is also a synergistic activity. Then tiotropium improves the health status and reduces the exacerbation and hospitalization as compared to placebo and ipratropium. So tiotropium is comparatively better than ipratropium. Glucocorticoids, they act as a multiple points within the inflammatory cascade, and their effects COPD are more modest as compared with the bronchial asthma. So in bronchial asthma they are more prominent because it is more as a inflammatory disease, bronchial asthma is, and therefore glucocorticoids are not as effective as they are in asthma. The patient with more advanced disease usually classify as a FE1 is less than 50% predicted. There is evidence that inhaled corticosteroids can reduce the number of exacerbations per year. In that condition it is beneficial. So let us see the table which is showing what are the important outcomes it is making. So what we have got various medications, what are their effect on FE1, what are their impact on the lung volumes, dyspnea, and overall quality of life, what is the changes. So beta agonists are, yes, they are causing improvement in the lung volume, they are decreasing the dyspnea and improves the FE1. Same is the case with the ipratropium, and this does not have any big impact on the quality of life. Long acting, they are having good, everything is good, they are improving FE1, they are causing the improvement in the lung volume, they reduce the dyspnea, and there is improvement in the quality of life. So same is the tiotropium, same is with the inhaled corticosteroid. However, they do not change much about lung volume, but yes, they are improving this FE1, then dyspnea and quality of life. Theophylline is also beneficial, and these are various observations the people are having. Adverse effects, there are comparatively lesser with the short acting beta agonists. They improve the exercise endurance. They are disease modifier by this FE1. Mortality data is not available. Side effect wise, they are having some side effects. Same is the case with the ipratropium. Long acting also having minimal side effects, tiotropium minimal. Corticosteroid, they do have some side effects, and theophylline is have to be considered because it have quite prominent side effects. Then what we can do is go for long-term oxygen therapy. It improves the survival, it improves the exercise, sleep and cognitive performance. Reverse of hypoxemia supersedes concern about the carbon dioxide retention. Arterial blood gas is the preferred measure, or we have seen if nowadays we have oximeter. With that we get this blood gas measurement, and it includes acid bed information. Oxygen sources include gas, liquid and concentrated. Oxygen delivery methods include nasal continuous flow, pulse demand and reservoir cannulas for transtracheal catheters are there. On that basis it can be there. Physical indication for oxygen includes arterial oxygen tension, that is PaO2 is less than 7.3 kilopascal or 50 mm of Hg. The therapeutic goal is to maintain this partial arterial oxygen pressure more than 90% during rest, sleep and exertion. Active patients require portable oxygens because they don't have they cannot have sufficient breathing, so oxygen is essential. Oxygen was prescribed during exacerbation. Then check the arterial blood gases after 30 to 90 days. Withdrawal of oxygen because of improved partial oxygen pressure in patient with documented need for oxygen may be detrimental. So if it is required and somebody says it can be withdrawn just because of there is a improvement in partial oxygen pressure, then it should not be done. Patient education will improve the compliance, so that patient will do everything in correct way. Long-term oxygen therapy can be done at home therapy also. That is whenever it is less, go for supplement of oxygen, and check it time to time what kind of so when there is a hypoxemia, that is decrease in the oxygen amount in blood, then and there is a decrease in this O2 level by less than 88%. If you nowadays in COVID it is happening, so we go for oxygen treatment so that it should be more than 90. Then the flow should be titrated in such a way that this percentage wise it should be more than 90% during exertion and sleep. Then accordingly oxygen can be given, and simultaneously other treatment will be there. So this is how we can go for the oxygen supply. Then pulmonary rehabilitation is a multidisciplinary program of care. It is individually tailored, and various measures are taken in that: exercise training, education, psychosocial behavior intervention, nutritional therapy, then outcome assessment, and long-term adherence to this is recommended to these people. Then nutrition, the weight loss and depletion of fat-free mass is done. The being underweight is associated with increase in the mortality risk, so go for weight improvement. Criteria defined is weight loss should, if it is greater than 10% in the last 6 months or more than 5% in the past month. See, this is different weight loss than people do for those or obese people do with exercise or something. This is the weight loss because of insufficient oxygen there is a decrease in the growth, and there is a decrease in the tissue formation. So there is a weight loss. So that is actually the problem. Nutritional therapy may only be effective if combined with the exercise and some other anabolic stimuli. So if the BMI is less than 21 kg per meter square and age is greater than 50 years, then we'll call it as underweight. In case of normal weight, BMI is less than 20, rather 25, between 21 to 25. Then overweight, if BMI is less than 30 or more than 25, and obese will call it at a if the BMI is more than 30. So depending on that, accordingly we can go for treatment, and accordingly nutritional are provided. Surgery can be done for reduction in the lung mass and improvement in the flow. So these surgeries can be done, and this surgery will result into a decrease in the mass of that. So this and it can improve the carbon dioxide diffusing capacity, that is we call it as a DLCO, that is diffuse lung capacity or carbon dioxide diffusing capacity of the lung. So this can be improved with the surgery. So these are various surgeries, we call it as a bulectomy and lung volume reduction surgery, which can be improve the spirometry, lung volume, exercise capacity, dyspnea, etc. And lastly, lung transplantation, where already lung has damaged too much, alveolar structure has lost, which is lost in the emphysema. If you will study emphysema pathophysiology, you will find that the alveolar structure is lost, and because of that it happens. So to make them survival, because otherwise death is only the option, but if we want to survive them, then the only thing is lung transplantation will be the option. So these are various parameters, this various surgery for that will not go for the details. These are various, that is these are surgeries, that is bulectomy, for that in what condition we can give it, and what simultaneously we can do is this is what details are given. Same is the case of lung volume reduction surgery, what are the condition, in what age group we can give, at what physiological conditions we give. In all cases, surgery is the last option when our pharmacological therapy is not successful, when FEV is reducing considerably, or it is almost less than 40% or 45%, then we are thinking about it, because it is not improving after treatment. Then same is about lung capacities are reducing, and in that cases only we are going for surgery options. Then same is the case with the lung volume surgery. The patient should have good sleep as far as possible, because what is important is sleep is associated with the oxygen desaturation, and it is predominantly due to disease itself rather than to sleep apnea. The desaturation during sleep may be greater than during maximum exercise. Sleep quality therefore will be impaired, and because of that it will also affect asthma also, that is COPD also. So it is a vicious cycle. COPD will affect sleep, and sleep will causes increase in COPD. So it has to be broken. Management of sleep problem should be particularly focused on the minimizing sleep disturbances by measures to limit cough and dyspnea, and nocturnal oxygen therapy is rarely indicated in some cases, because if the oxygen demand increases, then it will cause cough like reflexes. Hypnotic should be avoided with severe COPD, because they can cause respiratory depression, and already there is a decrease in the respiration rate. So we should not use hypnotic drugs, which you will be studying under drugs acting on CNS. So hypnotics are the drugs which are inducing or which are helping the sleep. Lastly, air travel, it has been found that at higher altitude the oxygen pressure reduces, atmospheric oxygen pressure will be reduced, and because of the reduction in the osmotic atmospheric oxygen pressure, the people will have lesser oxygen, and it can be a serious condition these people can have. So in that cases what we can do is the person can already give that detail to the airlines. Airline can have a thorough checkup before the patient goes to the aircraft. Air oxygen supplies are available, and then the patient can take oxygen in the airplane itself, but before that checkup will be essential. Now exacerbation means already there was some COPD was there, but when some treatment is going, some other thing is going, it will cause increase in the disease. We call it as a exacerbation. Exacerbation means already there was a small disease, it was manageable, but all of a sudden because of some other factor there is a too much increase in that disease problem, and that is called as a exacerbation. So we have to check why there is a exacerbation and what can be done in that patients. So this COPD exacerbation is that an acute change in the patient baseline dyspnea. There is a dyspnea, but it was managed, it was stable, and all of a sudden there is a cough or sputum beyond day-to-day variability sufficient to warrant a change in the therapy. Causes of exacerbation can be both. It can be because of the infectious, it can be non-infectious. Medical therapy including bronchodilators, corticosteroid, antibiotics and supplemental oxygen therapy can be given during this condition. Then indication for hospitalization with COPD, presence of high risk comorbid condition including pneumonia, cardiac arrhythmia, CCF, diabetes mellitus, renal or liver failure, because these are also affecting patient's status. So they can cause, we call it as a comorbid diseases. So these comorbid conditions will, comorbid means which are simultaneously making the person ill, or it is affecting the current disease. Inadequate response of the symptom can be there to the outpatient management. There is a marked increase in the dyspnea. There is inability to eat or sleep due to symptoms. The hypoxemia, that is oxygen level in the blood is reduced. Worsening hypercapnia. So there is carbon dioxide levels are increasing, changes in the mental status, and uncertain diagnosis will be there. Hello? Hello? हां बरं, अजून तर नाही आलं, त्यांना बनवून बोलवलं होतं मी सगळं. ठीक आहे, आलं तर 4 लाईनीचं आपण फक्त कवरिंग, तुम्ही निघण्याच्या आधी आलं तर बनवून घेऊ आपण. ठीक आहे, ठीक आहे. त्याने अजून आणलंच नाही ना, एवढा उशीर. त्यांना मी खूप रागवलं त्यांना. हां 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 बरं. आता अजून तर काही पत्ता नाही. त्यांना म्हटलं तुम्हाला आम्ही बोलवलं तेव्हा तुम्ही येत आहेत, कसं करायचं तुमचं काम? ठीक आहे ना, ठीक आहे. हां हां चालते ना, ते इम्पॉर्टंट आहे, ते करून घ्या. नाही, आणि काय करा माहिती आहे का, माझा असे सल्लाच होता तो पण, की आधी तिचं होऊन जाऊ द्यात, मग आपण यांचं देऊ, है ना. हां नाही, कारण ही त्यांच्याकरता अडचणीचं बात आहे, ते बिथरून जातील. तिचं करून, हां तिचं काम आधी काढून घ्या, है ना. चालतं. हां अच्छा. हं, हं, हं. अच्छा. नाही काय झालं, माझं ते 4th इयरचं क्लिअरच करून टाकलं. जे थर्डचे काही विद्यार्थ्यांचं होतं ना, त्यांचं उत्तर संपलं आता. म्हणे सर आता आम्ही, हां हां अच्छा बरं. चाल बरं, तुम्ही तिकडनं उशीर होईल तुम्हाला जर आल्यानंतर तुम्हाला हे होत असेल. हां नाही, आपल्याला ते सगळं मागचे सर्क्युलर शोधून ठेवायचे होते, की परत परीक्षा होईल काय होईल ते आपण पुढच्या भेटीत त्यांना करू, है ना. तर उद्या आपण सगळे 11ला परत बसू पाहिजे तर. चालतं आहे, ठीक. ओके चालतं आहे, ठीक आहे ना. चालतं आहे, चालतं आहे. ओके हां. So these are the conditions which are resulting into exacerbations. Check out whether there is a worsening the condition and accordingly go for the treatment. then this will indicate the severity of the condition from mild, moderate to severe. These are various criteria, whether there are some comorbid condition. Comorbid means simultaneously any other disease, as we have seen earlier, which is affecting. Maybe they are having asthma apart from COPD. If somebody is having CHF, congestive cardiac failure, or somebody is having other respiratory conditions. So these are why what we call it as a comorbid conditions. Then what is the history of frequency of exacerbation, how many times it is happening. If it is having occurring less time, then we'll have level 1. If it is having more time, then we'll go for level 2. If it is too much, then there will be level 3. Check out the physical findings, whether hemodynamically stable or not. If stable, then what are the additional respiratory muscles. Then tachypnea is there, that is increase in the respiratory rate is there without benefits. Persistent symptoms which are there, if their symptoms are not remaining, then it is a good condition. But if after treatment also symptoms are there or they are increasing, then we need to go for some other thing. What are the diagnostic procedure we shall go for checking or verification of these exacerbations? Oxygen saturation, arterial blood gases, chest radiograph, that is x-rays, blood test, serum drug concentration, sputum staining, example tuberculosis, electrocardiogram. This will check, and accordingly we can go. So this will help us to understand it in better way, and accordingly we can go for the treatment. So check out at various level. It can be if level 1 is there, it can be done at outpatient treatment only. We need not to go for hospitalization. But level 2 and level 3, the patient has to be hospitalized, and accordingly we should go bronchodilators, oxygen supplement, corticosteroids, and some antibiotic if already bacteria has been found in the clinical test. In level 3, same thing is there. Ventilatory support may also be given. See, oxygen can be given in different ways. Simple oxygen mask was okay in level 2, but if it is not sufficient, then give for ventilator like support, give bronchodilator, give corticosteroids, give antibiotics, and thus it should help the people. Then go for oxygen therapies, go for assisted ventilations, so that the partial pressure of oxygen, which was drastically reduced, will be going beyond 90%. So this is how we are going for the treatment. Assisted ventilation means use the various ventilated positive pressure ventilators are there, and there are two type: invasive, non-invasive. Non-invasive means mask like, but with positive pressure is there. Other non-invasive is just tube is there with small 2 holes are there, and only oxygen saturation they are increasing in the nearby air. These are 2 non-invasive. And in case of invasive, there is a tracheotomy is done, and the ventilator machine is applied. All the respiration is mechanical ventilation or mechanical respiration is there. So this can be done in this patient if required, and the care should be taken sufficient in this patient. So this is how patient should be trained for various things. Patient should be trained for various exercises, and patient should be informed about the compliance, how it is important. This is how we can take care about the patient. So this is all the treatment of COPDs. We shall discuss about treatment of bronchial asthma in our next class, so that it will be easy. There are big changes in the you can understand, because pathophysiology wise, this COPDs, although asthma, I am repeating, although asthma can be one of the COPD, but COPDs as such are different. Bronchial asthma are separately diagnosed as a bronchial asthma. In bronchial asthma, there is immunological and inflammatory mechanisms are involved. Although in COPD also inflammatory mechanisms are involved, but they are not prominent, they are not contributing too much. And here what is contributing is the structure has been changed, particularly alveoli or lung structure. That makes problem in the respiration and the surface area available for exchange of gases. So COPD therefore is a different than bronchial asthma that way, and because of that, what's the treatment example we have seen, glucocorticoids, they are not much effective in COPDs as they are effective in bronchial asthma. So these all things has to be kept in mind, and accordingly treatments can be checked. So we shall see about bronchial asthma in our next class. Okay.